Welcome back, everyone. Thank you for staying tuned. Now, just before we start this session with Bone Health, I just wanted to make sure everybody knows we are getting a lot of questions. So please keep filtering them through the Q&A session, and we will get to as many as we can. So I appreciate you being patient with that. Also, keep on chatting to one another. I know a lot of you have been having a very active chat session, so that's great to see. Next, we're going to talk about bone health, and then we will finish our day with our drug development roundtable, which will have a pretty robust conversation with a panel. So now I would like to introduce you to Dr. Sankar Bandyopadhyay. He goes by Dr. Bandy. He is originally from India, and his U.S. training was done at the University of Wisconsin Marshfield Clinic and at the Medical College of Georgia. He is currently a neuromuscular neurologist at Penn State Health and is the medical director of the MDA Care Center and the principal investigator for the university. So Dr. Bandy, welcome, and I will turn it over to you.
Thanks, Nicole. Welcome, everyone. And you can hear me clearly, right?
Yes, we can hear you.
So, so I have actually no the slide, the previous slide. So I have no disclosures, although our Penn State is part of the mover where we'll be collecting data for natural history, and then limb-girdle muscular dystrophy is part of that. But there is nothing to disclose related to this presentation. There might be a brief mentioning of some brand names because there are a few medicines that people are more familiar. So I will mention that when I will go there. So when MDA actually, the representative from MDA requested me to have this lecture, I was pretty surprised because I did a lecture of bone health for myasthenia gravis, I think 2 years ago. And then I did a mental health screening and psychological aspect of myasthenia gravis. And that was also a year or 2 years ago for MDA. And then when I got this request, I was a little surprised because if you do a research, and I will tell you how doctors or physicians or scientists research, the most common research tool is the PubMed, also called PubMed line. And there we do the research and we type the diseases and the conditions and we see what kind of research has been done. So when I did the research with vitamin D, some patients with limb-girdle muscular dystrophy, they were included. And when I did the osteoporosis and osteopenia research, then limb-girdle muscular dystrophy was not included, and I will come to that and I will explain why. So this is the status of research. So, and this is important because so far the lectures that you have heard were from experts who knew what was there, and then you heard from them what has been known from there. So I'm going to actually talk about what is important, what is dangerous, and what is not known, and what needs to be known. So it sounds like an COVID-19, all four headlines. What is important, what is dangerous, what is not known, and what is there to be known. Actually, the slide before, the previous slide, Nicole. So there's only one study from United Kingdom, and that showed decreased bone mass. It was not for limb-girdle muscular dystrophy. It was predominantly for the dystrophinopathies like the Duchenne muscular dystrophy and Baker muscular dystrophy. And they had only 9 patients suffering from limb-girdle or diagnosed with limb-girdle muscular dystrophy, and of which 4 were ambulatory and 5 were non-ambulatory. And the way things were done in England and maybe still done in European countries is not the way we do studies for osteoporosis or osteopenia in the United States. In the United States, we do X-rays. This is called DEXA bone scan, but this study was ultrasound. And in the United States, ultrasound is not an approved technique. You might see those trucks coming to your area. They're saying, we'll do your osteoporosis study for $60. And you ask your doctor, is this really good? And you hear this answer, no, they're not authentic. So that's the ultrasound. They go to your locality with an ultrasound machine, and then for $60 or something, they will do either your ankle or your wrist, because ultrasound will not be enough for the lumbar spine or the neck of the femur. These are the two sites called the central axial areas, which are studied in the United States with the DEXA bone scan, which is a form of X-ray. So we do not even include wrist or ankle. We do not talk about that. And that is not counted as authentic areas, and ultrasound is not included. So this study is basically, if you go by US standards, you will almost delete this study because this was ultrasound and this was done from wrist. But I will tell you, initially when I went over this study, I kind of disliked it. It was like because of my US background. But then towards the end, I found some data, which I will discuss later, is that with the ultrasound, you can study muscle health. And the muscle health and the bone health, particularly the osteoporosis related health, are very closely related. So then I started to like the study, and towards the end, I almost wondering whether something like that could be done in the United States. So next slide. So the other conditions included, as I mentioned, the Duchenne muscular dystrophy, Baker muscular dystrophy. So it's unrelated, but some of the limb-girdle muscular dystrophies that Dr. Wicklund was mentioning earlier as the sarcoglycanopathies. So those conditions might look like this Duchenne and Baker muscular dystrophies, and but that's not the topic for me. And facioscapulohumeral muscular dystrophy. So as you know, actually the previous one, yeah, the previous slide, yeah. As you know, just to be politically correct, the facioscapulohumeral muscular dystrophy has a predominant type, or type 1, and that's about 97 to 98%, and that's not regarded as an limb-girdle muscular dystrophy, but the relatively uncommon type, about 2 to 3%, or type 2, that is actually a form of limb-girdle muscular dystrophy. And I think in future, this facioscapulohumeral muscular dystrophy might be included as another form of limb-girdle muscular dystrophy. Next slide, please. So the ultrasound study from England, this study, and the reason for which I started to like these studies is that they took these patients and they divided into those who had decreased physical activity. And of course, there were definitions of what you mean by standard physical activity. And then they also were able to study with the ultrasound the muscle mass. And so sarcopenia is a hot term now. There are multi-million-dollar research going on sarcopenia. Sarco means muscle and penia means deficiency. So if you have a fracture and if you don't move, your muscles become atrophied or shrunk. I think you have seen that. Or if you have a surgery, or if you have a significant illness for which you're bedridden, or patients who get a stroke or trauma, they wake up after 4 weeks or 6 weeks, their muscle mass is gone, and then the physical therapists work on them. So that's the sarcopenia. So the muscle is, as you heard also from Mary Kingston, is muscles are like use it or lose it. But who tells the muscles that you are being used or you're not being used? It's a mystery. So that's the research going on to find out the genetic expressions, that if you are, say you have a fracture or you have a disease and you are bedridden for 6 weeks, who tells the muscles that you're not being used, therefore you're not needed, therefore you may die? That sarcopenia or muscle deficiency is genetically expressed. And this is closely related to bone health, and we'll discuss that later. Next slide, please. So the one other condition that is in the PubMed is a Pagets disease in limb-girdle muscular dystrophy 1A. As you know, 1 means autosomal dominant, and N is the first condition described as the autosomal dominant. So I think most patients have 2. But again, Pagets disease is not in our discussion today. Pagets disease is an uncommon disease where you have extra bone formation. No, the previous one. The previous slide. It's an extra bone formation, but because they're made in a hurry, they're not good quality, so there could be fractures. But there is possibly some genetic linkage of the gene that causes Pagets disease and the limb-girdle muscular dystrophy 1A, and there's just one family with 9 members, but that's not what we're going to discuss today. Next slide, please. So what we studied was vitamin D deficiency. And all the adult neuromuscular patients were included. And of course, patients with limb girdle muscular dystrophy were also included. But we found that about half of the patients, about 50% of the patients, they had vitamin D deficiencies. And I will discuss in subsequent slides more about the numbers. And then in subsequent studies, actually the third study, we found that there was about 55% of the adult patients who work in the neuromuscular clinics in Penn State, Hershey, they had either osteopenia or osteoporosis. These two are conditions in the same spectrum, and I will define them in the subsequent studies. And so these patients were naive or free from steroids. Next slide, please. So let's first discuss vitamin D deficiency and then osteopenia, which is a relatively milder form of the condition, and osteoporosis is a more advanced form of the disease. So what role does vitamin D play? So we know, let's take the kids. If they have vitamin D deficiency, they can have a condition called ricket. In the ricket, their bones are not strong. And as they are weight bearing, the bones become bent, they bowed. So they have bowed legs. Then there is a condition called osteomalacia, that is the adult equivalent of rickets. But because most people at this age, their growth is done, so they don't have the bowing of the bones as you see classically in the internet pictures, but they have weak bones, pains, fractures like that. But some young adults, they technically are 18 years old or 19 years old, they're called adults, but they still continue to grow. Nobody says that growth stops at 18 when you go to college. It can continue, so they can also have osteomalacia by definition, but they may look like patients with rickets. But again, that's not our discussion. So the way vitamin D deficiency can affect an adult, or maybe a child also, is by this. Vitamin D is one of the main function is to keep the calcium concentration in the blood. So vitamin D is needed for calcium absorption from the intestine. So the vitamin D that we take with food, it gets modified. And then eventually the final form of the vitamin D made by the kidneys are important to absorb the calcium. So if the vitamin D is low, then you need the calcium. So then we have a small gland called parathyroid gland that is in the vicinity of the thyroid gland in your neck area. There are glands on both sides. And those glands will release a hormone called parathyroid hormone, or we abbreviate as PTH. So the parathyroid hormone will frantically absorb the calcium from the bones and throw it into the blood so that the concentration of calcium in the blood is maintained. Otherwise, your heart will stop. So that's a priority, and you pay the price of losing your bone for that purpose. So that's the vitamin D deficiency, which can lead to all kinds of bone problems, poor bone formation, destruction. Then let's discuss what is osteopenia and osteoporosis. So throughout the life, even before we are born, from mother's womb until we die, our bone health can be discussed as bone formation and bone destruction. And these two are continuous processes. We are always forming bones for the whole life, and we are always destroying bones. So the bone that you had 10 years ago are not the same bones that you have now, or will not be the same bones that you will have 10 years from now. You might think that bones written in stone or something like bone, they're like constant thing. Once you have a femur, that's your femur, and for the lifelong. Your skin has wrinkles, your hair turns gray, but your bones remain bones. Completely wrong. No other structure in the body has this continuous renewal and continuous destruction process as the bones. So there are two types of cells. So there are osteoblasts, they form the bones. And there are osteoclasts, they destroy the bone. And there is a harmony. So at about between 15 to 20 years of age, your osteoblastic activity is more than osteoclastic. That means you make more bones than you destroy bones, so you grow. And then for women, from that that stage, about puberty or 20 years of age or 25 to until menopause, the osteogenesis and osteodestruction or osteoblastic and osteoclastic activities are pretty much same. They match out. So their bones remain pretty much the same. And then after menopause, it has a sharp decline. But for men, they reach the peak about mid-20s. Up to that, the osteoblastic activity or bone formation is more than bone destruction. So it grows. And then after that, there is no plateau. They just reach the peak, Mount Everest, and then immediately come down. But the rate of destruction is slower than women. So if you typically, a woman gets, say, menopause at 45, which could vary, from 45 to 70, women will have a sharper bone loss than men. But probably at age 70, the curves become parallel and both men and women lose bone masses almost equally. So this is the concept. These are the concepts for vitamin D deficiency, how it can lead to osteopenia and osteoporosis. Next slide, please. So these are the vitamin D levels. Normal is 30 or above. If you talk to other doctors, like a multiple sclerosis doctor, they will say, no, I need 40 and above. 50 is even better. So at least 30 or above is technically called normal. Now, one might say, is it true that the higher the better, like vacation or money, the more the better? The answer is no. At some point, too much vitamin D can lead to kidney stones and other problems. So the mild to moderate deficiency will be the 21 to 29, and then severe deficiency will be 20 or below. Next slide, please. And we already discussed how vitamin D deficiency affects bone. So it will lead to, because the calcium concentration will be dropping in your blood, and heart will say, shall I stop? And then your body will say, no, you go on, and we need to sacrifice the bones. So the parathyroid hormones should be secreted. It will absorb the calcium from the bones. As you know, the whiteness of the bones is because of calcium. That's the same of milk. Milk is white because of the calcium. So as a result, you will have poor bone mass. And bones normally look like honeycombs. And I will show you pictures of normal bones with the honeycombing appearance and the osteoporotic bones. So then it can lead to osteopenia and osteoporosis. Remember, these two are related terms, and I will define them in the next slide. Next slide, please. Okay. So this whole concept, next, please. Next. Yeah. So the whole definitions and the understanding of osteoporosis and osteopenia, I should say the other way, osteopenia and osteoporosis is very different in European countries or European Union. Because here we use the DEXA bone scan, which is X-ray. We do not use ultrasound. It is not approved, except for those trucks that come to areas. I discussed that. And then the study is done from the lower part of lumbar spine, which is the low back region, and the neck of the femur. So the long bone in the thigh is called femur, and femur has a head with which it is attached to the pelvic bone, and then it has a short neck. So we study from femoral neck on both sides, and then also total hip. So that's the standard thing for actual study. And again, nobody studies, or unless you specify the wrists or the ankles, nobody specifies that. So the osteopenia is defined when there is a thing called T-score. That's between, so normal will be if your T-score is -1. -1 is normal at all sides, lumbar spine, femoral neck, and bilateral hips. Then the T-score, if it is between -1 to -2.5 at any side. So of the 3 sides, if you have 2 normal and 1 abnormal, then the final result is not mostly normal and slightly abnormal. The final result is you always take the worst count. So if you have any site out of these 3, lumbar spine, femoral neck, total hip, between -1 and -2.5, it will be osteopenia, which is bone loss, mild to moderate. Then you have osteoporosis when the T-score goes more negative than -2.5. So if you take the minus sign off, just remember that 1 or above is okay. 1 to 2.5 is osteopenia, and more than 2.5, like -3 or -3.5 will be severe osteoporosis. Now, there are also some ideas and views in the European societies to consider severe osteopenia as almost equivalent to osteoporosis. And our National Osteoporosis Foundation at one article mentioned that if your count here, say -1 to -2.5 is more than -1.5, then you treat them as if they have osteoporosis. So we have created this unofficial station of -1.5 to -2.5. And they are like near osteoporosis, and you treat them as if you would treat osteoporotic patients. Next slide, please. So we already discussed that the studies that we have done, we found about 50% of the patients were deficient in vitamin D, and we explained how vitamin D can damage your bones and lead to osteoporosis and osteopenia. And about 55% patients also had either osteoporosis and osteopenia. If you ask me what's normal, the answer is we don't know, like COVID-19. A lot of the questions, any question you ask, the answer is we don't know, but. So this is how the answers begin. So my answer will also begin. If you ask me, tell me what should the T-scores be in patients in central Pennsylvania? The answer is nobody has done any study. So the normal study against which I compared was from Mass General Hospital in Boston. So they studied the normal people, they had the funding, and I used their values as the values to be compared to. Now, you don't do that in other studies. So you don't do a study in Pennsylvania and for normals, you take it from Massachusetts. But because there are no values, no nationwide values, no real values for men and women at different ages. So if you take this picture, let's have a quiz. Well, I don't get the answers to the quiz. So which one is normal, the left one or the right one? If you show this picture, somebody will say the left one is like has some disease, like some infection or some pigmentation, etc. The answer is opposite. So the left is normal and the right is abnormal. You have lost the bone. As a result, it looks like that. Next slide, please. These are from internet, so you can look at this slide. No, yeah. So on the left is normal. That's the honeycomb. That's what the bees make. And then on the right side, it's rarefied. So that is osteoporosis. And again, these pictures are in the internet. If you just want to get this common knowledge about osteoporosis, it is nicely maintained. There is a Mayo Clinic site, there is a National Osteoporosis Foundation, and there's an International Osteoporosis Foundation. You will see, you will get the definitions, all these pictures, and what to do, what not to do kind of thing. So next slide, please. So that will be your X-ray. So sometimes the diagnosis comes from, somebody says, hey, I did the X-ray because I thought there was a fracture. And then the one on the left is normal. The one on the right is abnormal because it's rarefied. So you see the whiteness here, here's the amount of bone, and it's just rarefied. Next, please. So these are all pictures. You can look at these hundreds of pictures from the internet. So if this is your lumbar spine, then this is normal. The one, well, so that will be, and then the rarefied bones will be like this. Next, please. So the standard tests in the United States, in fact, I didn't know that there was any other test that could be done. I always thought that those trucks with the ultrasound, those should be banned. But the standard test is the DEXA bone scan, which are X-rays. And then it's a funny thing that because in Penn State, when I order bone scans these days, patients go and they have these arrows, COVID X-ray this way. And then they come back, they don't go there. And then I said, that's where the bone scans are done, the same area. So follow the COVID X-ray signs, arrows, and you will reach the correct site. But you won't have you will not share the time with the COVID-19 suspected patient. But so then patients go back. The sites we mentioned, lower spine and femoral necks. And this is interesting because insurance doesn't cover the test, the DEXA bone scan. And I will mention in one of the next slides is what are the conditions when they cover. As a result, bone scans are not done. You cannot just ask your doctor for a bone scan. And as a result, bone scans are not being done, declined by insurance companies. And then there were so many patients, then I just wondered, how much does it cost? I thought it would be several $1,000s because it's a DEXA bone scan, something like sophisticated. Then I got this answer from radiology, $250. So those trucks charge you $60 or $65 for ultrasound. And even if you do not care for your insurance, it's a $250 test. And this is important to know, and I will come back to this. Next slide, please. So these are the conditions when, if a doctor orders, the insurance will ordinarily, or Medicare will ordinarily approve. If you have spontaneous fractures, you woke up and you had some back pain or some thigh pain, no injuries, you didn't fall or anything, and you go to the doctor and they do an X-ray and there is a fracture. And they say, oh my goodness, how did you have this? Well, that spontaneous fracture, you will get a bone scans and insurance will cover. If you have unusual or nagging bone pains going on, you have tried physical therapy, you have tried the pain medicines like ibuprofen, nothing is working, there is no explanation. So after a long time, your insurance will be willing to cover this $250 testing. And just for one comparison, many people get CT scans when they go to the ER for headaches. Many people end up getting an MRI if they have suspicion for stroke. And ordinarily a CT scan costs about $1,200. And like me, if you have insurance like what I have, 20% of that, of $1,200 is $240, even if insurance pays. And if your insurance is like my insurance, for MRI, $4,000, actually $4,400 these days. So my copay will be 20% of that, which will be $880. And that's almost the price of 3 bone scans. I will also have some money left. So people have this stigma, oh, my insurance doesn't cover it, so I'm not going to go that. Very few people actually probe beyond that, and very few physicians, including myself, probe beyond that. Okay, how much does it cost? It's $250. With this, when I've told this to my patient, they said, fine, I will get it done regardless. If you are on steroid therapy, and there is a formula, if you are going to be on more than 5 milligram a day for more than 3 months, so 5 milligram a day for more than 3 months, then they will cover it. If you have seizures or epilepsies, and if they are giving you some medicines that can technically cause osteoporosis, insurance will cover it. Women more than 5 years after menopause, and that menopause has to be either declared clinically or measured by hormones. How about women before menopause or within 5 years of menopause? What about men? Those are the patients, they are not included. Either you have to have a spontaneous fracture, or you have to have this nagging pain for 3 months or more, or you have to be on steroids. And limb-girdle muscular dystrophy patients have no reason to be on steroids ordinarily. And hoping that you don't have seizures, because that's not a common association of limb-girdle muscular dystrophy with epilepsy or seizures. So basically it will be very hard if you are a woman within 5 years, before 5 years of menopause, or a man of any age, unless you fulfill the 4 conditions, your insurance might decline a test. Next, please. So we discussed the 2 constant process of bone formation or osteogenesis and bone resorption or osteoclasis or osteoclastic activity. And remember, this starts before we are born in the mother's womb, and it goes until we are dead. It's a continuous process. I'm going to repeat the information. At around puberty, there's an upsurge of bone formation. That's why we grow. And for women from puberty to menopause, their balance remains more or less same. They make as much bone as they destroy. Men continue to make bones up to the age of about 25, and then they have a sharp decline. And it goes on. But the decline is lower than women from menopause 45 to 70. So men have lower rate of decline between 45 and 70. Women have a high decline. From 70, it becomes normal. Next slide, please. So the treatment, many people says I have osteoporosis, my doctor diagnosed this, I'm on treatment. What is the treatment? To be honest with you, there are two types of authorized medicines. One is called biphosphonates. And again, I'll just briefly mention, some people also call it alendronic acid. And there are several preparations, and some people might remember the name Fosamax, but that's a brand name. I have no relationship with those manufacturers, but many people know this drug, biphosphonates, as Fosamax. And then another drug as denosumab. If I say denosumab, it will sound like a dinosaur. But there are two forms, two medicines. Those are brand medicines in the market. One is called Xray, the other one is called Prolia. I think Prolia is a little bit more popular because it's once every 6 months. Again, these two, the Xray and the Prolia, are brand names, but they are denosumab. The biphosphonates and the denosumab both work on the osteoclasts, the cells that destroy the cells, so they slow down the destruction. They have nothing to do on the bone formation. The biphosphonates are taken by the bones, and then they bind with the hydroxyapatite, certain chemicals within the bone. And when the bone destroying cells, the osteoclasts come, they have either, number one, binding because of the biphosphonates already binding, or they bind and they swallow the biphosphonates. As a result, some of them, the osteoclasts, the bone destroying cells, are rendered inactive or they die. So that's the mechanism. And for the other one, the denosumab, the MAB stands for monoclonal antibody. These are hot products. For migraine, you have monoclonal antibodies. For MS, multiple sclerosis, you have monoclonal antibodies. You have monoclonal antibodies for many neurological and non-neurological conditions. So MAB means monoclonal antibody. And the first part is usually either the name of a girl or a boy or a place or somebody's nickname. It goes like that. For example, the first drug for multiple sclerosis was called natalizumab, so that Natalie was the name of a person. So denosumab, how do they work? They're antibodies. They bind with the osteoclasts and then they destroy the osteoclasts. So as a result, you may have extra bone formation in areas. Now our whole body doesn't go at the same rate. Your lower spine, because of the weight bearing, and the femoral neck and the hip bones, because of the weight bearing, they may lose bones more than they are forming bones. But there may be jaw bones that are not weight bearing. So you can have excessive bone formation in your jaws, and there could be necrosis due to lack of blood supply. And so that's one of the very rare, not rare, I would say uncommon, but dangerous side effects of both. They can cause fractures, necrosis of the bones. Next slide, please. So to what extent do they work? Now, I struggled to find out these medicines, these osteoclast class modifying medicines. What is the best statistics? So the best statistics that I have had or found is that they can decrease bone destruction by 4% in a year. So if I am your doctor, I do a bone scan and I say you have osteoporosis and I give you one of those two medicines. And I say, I will do another scan in 5 years. In 5 years, you will have 4%, so about 20% slowing of your bone destruction. You're not going to make more bone. And this part is important. You're not going to make more bone by taking those medicines. So you're only reducing it by 4%. And so your bone density testing will always be worse in future. 1 year down, 2 year down, 5 year down. So it will be less worse than if you're not on any medicines. So it is not adequate. So how to promote bone formation? The doctors have nothing to do with that. So all these sites, I request you to go to the Mayo Clinic sites, which are free. You don't have to pay anything for osteoporosis. There is National Osteoporosis Foundation and there's International Osteoporosis Foundations. And then all of them have these sites that are totally free. If you have internet, you can go there and you will see that the research has shown that the bone forming exercises are exercises where you have to pull the bone. And who pulls the bones or joints? The muscles. So the bone health discussion is absolutely bogus without discussing the muscle health. And our DEXA bone scan doesn't check muscles. And the ultrasound is fantastic for checking muscles, but US doesn't accept ultrasound as a standard method because you cannot measure lumbar spine or femoral neck with ultrasound. Those are deep structures. You can measure wrist or ankles because those are kind of superficial. There's not much of muscle or fat. So here's the dilemma. At some point, we have to combine the two for doing a bone study as well as muscle study. So these are the exercises that stretch a joint, muscle stretching exercises. Those are walking, not running. Why? Because you have to pull it for some time. You have to pull and hold it for some time. So if you're walking, you are using muscles, yes, you're pulling, but within a second, the pull is gone because the other side is taking over and then the other side is taking over. And if you're running fast, if you're sprinting, then you're not getting any exercise. And this has to be done against gravity. So the swimming is not included. So this is very frustrating because swimming has nothing to do with your osteoporosis prevention or osteoporosis improvement. Jogging or walking doesn't have. Your Zumba dancing doesn't have anything to do. Your fast aerobic exercises have nothing to do. Anything that you're doing fast, you're alternating between two sides, either two arms or two legs, and that doesn't count as a sustained muscle stretching. So walking does count. Dancing in some forms, not the fast aerobic dancing, Zumba, not like that. The low impact aerobics, ellipticals work, and ellipticals are laughed at. Many people say, oh, you're doing elliptical, why? Come, run. So ellipticals are good for from osteoporosis point of view. Stair climbing, if you have a house, you have a free bone exercise, bone forming exercise. And remember, your doctor, your medicines, your pharmacy have nothing to do with your bone formation. You have to stretch your joint and bone with the muscle, that's it. And gardening, because you're constantly bending and then remaining there for some time, and then you are standing and stretching. Whatever you're doing, you are doing it for some duration. So the question is, yoga should be a good one. Next slide, please. So before we go to yoga, so this is a good slide. So swimming, we discussed, running, cycling, very frustrating because so many people are out there with their bikes. It's good for many things, but don't expect to make new bones. And high impact aerobics, and golf, tennis, and bowling. I know many people are frowning their eyes. So golf, tennis, bowling, and these are all from those sites, either Mayo Clinic sites or the Osteoporosis Foundation sites. And the yoga, some postures do that and some do not. That's beyond the scope of this. But always go through a certified yoga person because many people have broken their bones with osteoporosis. They called a yoga doctor, a yoga person, and without telling that they have osteoporosis, they started doing yoga and then they bent and they had a crack in their spine or femoral neck. So the yoga should be done through an expert who should know that you have osteoporosis and who should know the relationship between osteoporosis and yoga, like which postures to do, which postures not to do. I will give an example. There's a common posture called tree position, where you stand on one foot and take the other foot, the sole of your foot, and you touch the sole against the knee, the other knee on which you're standing, the knee of the leg on which you're standing, and you look straight. So here you're not bending and you're stretching bones, and you take 10 breaths or count to 20 or 40, something like that. So those postures, the tree position or tree asana, will be regarded as a good one, but not the other ones. So remember, unsupervised bending and twisting can lead to fractures. Next one. So why is that the bone health, bone density, or even ultrasound in European Union is not standard? Standard means what? You go and doctor checks your fasting sugar to see if you have diabetes. Women get a pap smear every year or every other year. Women of certain age get a mammogram. Men after 50, or men and women both from 50 onwards, they get a colonoscopy every 5 years. And there are some guidelines for checking prostate-specific antigen for men. So these are standard, means insurance will cover it completely. There's no copay or deductible usually for a good insurance. But there is no standard practice to check for bone density unless I mention if you have a spontaneous fracture, if you have refractory nagging bone pains, and you have to define refractory. You have to say, I've seen doctor after doctor, I have done therapy after therapy, I have taken pill after pill, X-rays are normal, scans are normal. So then the definition of refractoriness will come. Or you have to be on steroids, more than 5 milligram for 3 months or longer. Or you could be a woman 5 years after menopause. That's pretty much it. But the question is, and that is why many physicians do not order, because it is going to be canceled, declined, and patients say, no. If insurance doesn't cover, I'm not going to pay it. But many unnecessary CT scans are done, and you pay 20% of that, which is $250, or many unnecessary MRIs are done, and you pay, if you have insurance like what I have, $800 to $900, and you are happy that your insurance covered it. But this is a $250 test. Again, the price should be verified. This is at the Penn State X-ray. It might be different, but it's not going to be $1,000. It's not going to be $500. It will be ranging between $200 to $300 probably. And it's so important to know, because you can do so much in terms of modifying the bone destruction. That will be your doctor giving you medicines, or doing exercises that will stretch your bones and will make new bones. You might be joining tennis, you might be swimming, you might be playing golf, you might be doing yoga, and those are not useful for these purposes. So we need technical knowledge for that, but before that we need a diagnosis. Next please. Next slide, please. So sarcopenia, I'll just spend a few minutes. Sarco means muscle, penia means deficiency. So muscle deficiency, it is an enigma. Like, who tells muscles that you are not needed? Like, you heard the term, use it or lose it. Like money. If I have $20 and I had a fracture and I was on bed for 6 weeks, the $20 was on my book pocket in my shirt. So that will still be there, right? When I wake up and my class, everything taken up, and I still have my $20, but not for the muscles. Before I fractured, if I had 20 units of muscles, I am free after 6 weeks, all healed. I will have 15 units of muscles. I will lose 5 or more units of muscle. So who tells the muscles? Muscles are like mechanical structures. They can be alive. You can take a muscle from a dead person, you can give circulation, you can charge them with electricity, and that is what is done in the labs. You have seen with a frog muscle, the frog is dead, and the frog died 3 weeks ago, and you have the muscle, which is soaked in nutrients. So the muscle gets some nutrients, it is alive, and you give electrical shock currents, and the muscle responds, and you study. This is how our electromyography or EMG has been developed. So that means the muscle is still responding, it's not dead. So muscle is like a chemical structure, an electrical activity with electrical activities. So who tells the muscle you are not needed, you may go? So there are the genes, and there are few genes that have been described, and this is updated up to last Tuesday when I submitted those to Nicole. Until that day, and some of the genes were just described during COVID-19 thing. So within the last 1 or 2 months. So we have these 1, 2, 3, 4, 5 genes, but there could be many genes that are active. Like if you're not working, if you are in a bed, they tell another gene, and that gene tells another gene, and somehow the muscles get the signal that we don't need you. Some of you could be furloughed, just like what is happening. Many institutions are working at a 20%, 40%, 50%. So the workforce that they had, many of them are furloughed. They said, we might call you back, but for the time being, we don't need you. And the sarcopenia adds to the muscle loss. And so if you have a muscle disease, say limb-girdle muscular dystrophy, you are losing muscles because of 2 factors. One, you have limb-girdle muscular dystrophy. Some of the muscles have some genetic problems. As a result, you're losing muscles. And because of loss of muscles, you are becoming less active. Because of becoming less active, you're also losing muscles. And it's a snowball. because of losing some muscles, you're losing some more muscles, and because of some more, you're getting some more, some more, and it goes on like that until something bad happens, like you say, I cannot walk and give me a wheelchair. So this sarcopenia is a neglected term. There's a lot of genetic research just started here in the United States as well as abroad. And we need to understand these genetic expressions because you had the gene-targeted therapies are there. So if we know these genes, we might also develop in near future gene-targeted therapy. So for example, I get a fracture and I'm going to be in bed for 2 months. I will get a gene therapy just for one time, maybe for those 2 months, so that when I get better, I will not have muscle loss. But if somebody gets a stroke and they recover after 3 or 4 months, but their muscles are gone. So this muscle atrophy has to be researched and we should be able to slow it down, if not prevent it completely. And that's absolutely important for any muscle disease, including limb-girdle muscular dystrophy. So muscle loss leads to more muscle loss. And so we need an ultrasound. So after hating that article until 50% of the article was read, I started liking that article. So gene therapy is the future. In future, gene therapies are for both sides. The defect that you have for limb-girdle muscular dystrophy, which could be autosomal dominant if you have a number 1, or autosomal recessive if you have number 2. And we have 31 to date, 8 autosomal and 23 recessive ones described. And the future for that is gene therapy, and the future to slow down the sarcopenia will also be gene therapy. And bone disease can lead to sarcopenia, and sarcopenia can lead to bone disease. So it is very important to know whether you also have a bone disease. When we did the study in our neuromuscular clinic, about half of the people had vitamin D deficiencies, and about half, more than half, 55% had bone disease, osteoporosis and osteopenia. And if your insurance doesn't pay, it's up to you whether you will pay this $250 and whether this test should be done, vitamin D should be done, or this should be done. Many of my patients, I am called the bone doctor, like the vitamin D doctor. So like everybody gets vitamin D checked, or many people get a bone scan done. So I think I'm the one who does most of these tests, because I want everybody to have a vitamin D level and a bone scan done. So next slide, please. So future we talked about, we need broad spectrum medicine, means not only the bone medicines, the ones we have, which will work on the bone destruction or osteoclastic, but also medicines to promote bone formation. And we need cheap and efficient technology. Some people do not like X-rays, and then ultrasound is cheap, but ultrasound is not efficient for deep bones. Gene therapy we talked about. And then artificial intelligence, we are running out of time. AI should be the future, because there should be a standard checklist. So a patient sees a doctor or a provider and something is done. Doctor orders physical therapy, doctor orders this thing, that thing. And at the end, when the provider is going to check out, the artificial intelligence says, no, not done. Talk about bone health. Then you talk about bone health, then you try to check out and be ready for the next patient. They say, no, not done. Mental health. So mental health is ignored. And I, in Philadelphia 2 years ago, I presented for MDA the mental health, which is ignored, just like bone health. So not until all these issues are taken, you will not be able to check out that person. So when that happens, you will get a little irritated, like a provider and the patient, and they will find out as an efficient way to, without wasting time, without talking about other things, weather, politics, COVID-19, etc. How can we utilize the time to talk about muscles, because you have a muscle disease in the first place, then gene therapy, then overall you, addressing the overall you, including mental health and bone health. Next, please. So this is what we're expecting. If you just eyeball on this for a few seconds. So I just went to Louvre and with my family and my 14-year-old daughter just last year. So of course they have this Mona Lisa picture, and the line is the longest if you want to see the Mona Lisa. And the Louvre was closed for COVID-19. And so was the Taj Mahal in India. Never in the history, during the Second World War, the Taj Mahal was open, the Louvre was closed. Never in the history, Vatican was closed, Louvre was closed, Eiffel Tower was closed, the Taj Mahal was closed. That's the only example is COVID-19. So this is a cartoon, and it seems the Mona Lisa has a sanitizing gel and there's a smile. So when will you see this Mona Lisa smile? That's here. So you can't see the smile. You know, these days when I wear masks, my patients do not know what emotions I have, which is good or bad. But you know, normally I say funny things to my patients, and normally during a presentation like this, I will have many humorous components because I cannot go without humor, without laughter for a few minutes. But so we are all hankering to see the Mona Lisa smile when this mask is gone, and that will happen when the devil is treated properly with a vaccine, not now. For the timing, we'll keep it. So thanks and stay safe.
Thank you, Dr. Bandy. That's pretty funny. Well, we do have quite a few questions. So let me go and start here. Is a once-a-year IV treatment of Reclass beneficial for limb-girdle patients to help with osteoporosis?
That you should check because, you know, as I know, the standard therapy is once every 6 months, or you're talking about the denosumab. And the other one, the alendronic acid, is once a week tablets. So whether once a year is enough, that you should check with your either endocrinologist or your primary care physician, but the standard recommendation is 6 months.
Okay. If a person doesn't drink milk due to milk intolerance, is there a natural way to get needed amount of calcium daily or a supplement? If so, what supplement?
Well, there are calciums, over-the-counter supplements, and there are many ways without milk. If you are intolerant to milk, you may not be intolerant to cheese, or you may or may not be. So, and there are other types of milk, like for example, the milk that I drink is almond milk. That is different from cow's milk. That's not cow's milk. That's a vegetarian milk, and that has more calcium than the ordinary cow's milk because they have added fortified with calcium. So that should not be a problem. You can, if you are allergic to milk, if you milk cow's milk, then you can have, and also find out what is allergy. Some people have lactase intolerance. Then there is the same cow's milk, which is lactate free. And then some people have problems with fat. So then you have a fat-free cow's milk. You might find. If you have problems with both, then you will have lactase-free, lactate-free, fat-free cow's milk, and try that. And if you really have trouble with that, then try almond milk or soy milk. Those have, and look at the calcium content, and you will see that some of them had more calcium than that. And yogurt, although it comes from milk, but it has bacterial activity. So you may not be allergic to yogurt, and also you can have non-milk yogurt. So these are all natural sources of calcium, and there are other sources of calcium also, which you can easily study. Just internet is so good. Google, just say calcium-rich foods, and then you will see a list of foods, and you will see that milk is not the only one. Those days are gone when you have to drink milk. And of course, if nothing works, then you have the calcium supplementation. See, we have no standard recommendations except for patients with epilepsies who take seizure medications, and some of those can cause problems. Then the recommendation is at least 1200 milligram of calcium daily. So remember, either 1000 or 1500, at least that much calcium daily should be good for you. But again, I'm just using the data from epilepsy world, and there is no data. Nobody developed the data for muscle disease or neuromuscular disease. It's totally underdeveloped. But so 1200 milligram.
When a limb-girdle person falls and hurts themselves, no broken bones, does it take longer for recovery than someone without muscle disease?
It also depends on the age, you know, and also it depends on the severity of the disease. So and it also depends on the bone that is broken. So if it is one of the axial bone, and if the presentation has been mostly in the limb girdle distribution. But let me tell you, although the name is limb girdle, which is mostly the pelvic bones and the scapula and the arm bone called the humerus, technically we call it the perineoscapulohumeral. But many people in many forms, they have weakness of the leg muscles. Leg is between knee and ankle. So many of them have calf muscle atrophy or hypertrophy. Many of them have the muscles that makes the toe go up. And in the absence of that, you can have a foot drop. So the tibialis anterior, those muscles, many people do not know that in about 15 to 25% or maybe a higher percentage of cases, they can have the distal muscle, the muscle that are away from the limb girdle are predominantly affected. So it depends on which bone and where is the status of your muscles surrounding the bone. If you are unfortunate to have a fractured neck femur, and if you have the classical limb girdle muscular dystrophy, there is a possibility that you might have osteopenia or osteoporosis, and the muscles might have been atrophied. So the healing time will be longer for various reasons.
Got it, got it. How long can you take bisphosphonates? This person saying she took Boniva for 7 years, but has since stopped.
Well, again, I do not treat these patients, but I am aware of the recommendations. The recommendation is after 4 years, maximum 4 years, you should have a test and you should have a little drug holiday and decide what's the net effect on you. Because remember, you may be osteoporotic in your lumbar spine and the neck femur, and as a result, you might have jaw bones hurting you, jawbone necrosis, because you are just making too much jaw bones or bones elsewhere. So an overall assessment should be done. This is in the recommendation. This is in the FDA recommendation also. 4 years after that, you should be assessed to see whether you have benefit or no benefit. If you had benefit, then it might be continued after a little break. But 7 years sounds like too long. So I think you should talk to your doctor,
Okay.
recommended, and definitely you should have a bone density and go from there.
Okay. And I'll take our last question. Is there a connection with parathyroid issues in limb girdle? I have had 2 surgeries and I am still having issues.
Like genetic association between parathyroid disease and limb girdle muscular dystrophy. I'm not aware of that because there's just one family who had 1A, so the dominant form of the autosomal dominant forms. They had this Pagets disease, which is still different disease. But I'm not aware of like the parathyroid gland being affected in limb girdle muscular dystrophy. We do not check for parathyroid functions. Sometimes when we have somebody with muscle weakness, I usually check parathyroid hormone for all patients. That's my day number 1 testing. But I have patients who came to me with a confirmed genetic diagnosis of limb girdle muscular dystrophy. I did not check parathyroid hormone for those patients, but that's a good question. So for every patient with a muscle weakness, I check parathyroid hormone in addition to some other hormones. Again, this is not recommendation. I just do that because I do not want to miss a muscle disease secondary to bone health. But that's a good question, whether every patient should have a parathyroid hormone checked. What's the yield? But that's a question. I do not have the answer for that.
Okay. Well, we are out of time for your segment. So thank you very much, Dr. Bandy. We appreciate you being here. A lot of information was shared.
Thanks.
Have a great rest of your Saturday.
Same to you. Thank you very much.
Bye-bye.
Bye-bye.